Welcome everyone to our Bold Public Health Center of Excellence on Dementia Caregiving webinar. Really glad you are taking the time to join us today. We're going to get started here in around a minute or so to give everyone a chance to join and get settled. So thanks again, and we'll be starting shortly. Again, thank you for all of you who have taken the time to join us here today for our Bold Public Health Center of Excellence on Dementia Caregiving webinar. We're just waiting for everyone who has registered to join the room. So we will be starting in the next 15 to 30 seconds or so. Thank you so much, everybody. All right, well, why don't we go ahead and get started? Welcome, everyone. My name is Joe Gogler. I direct the Bold Public Health Center of Excellence on Dementia Caregiving. Maya, if you go to the prior slide, please. And welcome to our webinar today, Natural Disasters and Dementia Caregivers, a roundtable discussion on public health action. I think all of you will agree that this topic could not be more timely, and we believe it's particularly relevant to consider national disasters in the context of dementia care. And that's really what this superb panel will be doing for you here today. Next slide, please. So again, you just see me here and my affiliations. Again, really excited to be helming the Bold Public Health Center of Excellence on Dementia Caregiving, and particularly for these webinars. They're very exciting. It allows us to essentially tailor content to disseminate information that is of the highest relevance, impact, and timeliness. And we hope you'll agree with us at the end of today's webinar. Next slide, please. I'd like to begin with a land acknowledgement. The University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn and honor their traditional cultural Dakota values: courage, wisdom, respect, and generosity. And when considering these values here, courage, wisdom, respect, and generosity, these certainly are values we try to embed in all of the various activities that make up the Bold Public Health Center of Excellence on Dementia Caregiving. Next slide, please. So what is the center? We call it PICO DC for short. It's just a little bit easier to say. But really the goal of our center is to elevate dementia caregiving as a public health concern, and to do so vis-a-vis robust engagement with local, tribal, state, and other public health entities across the U.S. You can see three of our specific objectives, which is really highlighting and improving access to evidence-based dementia care programs and practices. Also really encouraging and facilitating connections and collaborations, not only amongst public health agencies across different states and localities, but also public health agencies with other key stakeholder networks, for example, aging service networks within given states and communities. And then finally, our center also can provide technical assistance, again, primarily for public health organizations, but others as well, to help advance their respective work on really helping to support those who provide care to people living with dementia, and then to advance practice and services in these areas as well. Next slide, please. So I'm going to turn it over to the moderator of our panel, Dr. Regina Shi from RAND Corporation. Dr. Shi is part of our leadership committee of the Bold Public Health Center of Excellence on Dementia Caregiving, and really excited to hear her moderation of what's going to be an exciting panel for you today. Thank you, Regina.
Thank you so much, Joe, for the introduction. I'm so pleased to be with you today as one of our two moderators for today's webinar. Robin Stone is our second moderator. She's the Senior Vice President of Research at Leading Age, and she's also a member of our Center for Dementia Caregiving at the University of Minnesota. To set the agenda for our roundtable discussion today, I'll be giving a brief overview to scope our discussion, and then I'll step into moderator mode and introduce our 5 panelists. I'm going to be leading our 5 panelists through an informal Q&A-like discussion, which will last about 45 minutes. During this roundtable discussion, I would encourage you, the audience members, to enter your questions into the Q&A field in Zoom. After our moderated discussion today, I will then ask Robin to go through our audience questions that you submit through the Zoom Q&A field. And in the last 30 minutes, she'll walk our panelists through those questions from you, the audience. After today's webinar, we're going to have a short survey to gather your feedback on today's discussion, and the recording from today's webinar will also be available on the Public Health Center of Excellence Dementia Caregiving website, along with a list of resources that we've compiled for you on preparedness for natural disasters for older adults. And with that, let me turn to a couple slides to frame our discussion today. As you all know, climate change is increasing the severity and frequency of weather-related disasters, such as extreme heat events, floods, droughts, wildfires, hurricanes, and flooding, and more. The cost associated with each of these disasters continues to increase, and new disasters are emerging every day, including the COVID-19 pandemic as an example. Next slide. These natural disasters and public health emergencies hit older Americans the hardest. According to a national survey, 2/3 of older adults had no emergency plan and had never participated in any disaster preparedness educational program and were not aware of the availability of relevant resources. Also, 3/4 of those who perished after Hurricane Katrina were over the age of 60. Next slide, please. These demographic shifts are driving dementia-related challenges to disaster preparedness. You've heard the statistic that 10,000 baby boomers turn 65 each day, and that is translating into more than 7 million people ages 65 and older who had dementia in 2020. People with dementia frequently have comorbid health conditions that make disaster preparedness and response challenging. And more than 4 times as many people with dementia live in traditional community settings than in nursing homes. Therefore, for those community-based people with dementia, preparedness like evacuation planning needs to be individualized rather than at an institutional level. Unpaid family caregivers provide the vast majority of care for people with dementia, which means disaster preparedness inherently involves family caregivers. In addition, 1/3 of all family caregivers who care for an older adult are caring for someone living with dementia, which makes dementia family caregiving an important group to support. Next slide, please. Federal and state emergency management frequently frame disaster preparedness as 4 phases: preparedness, response, recovery, and mitigation. The responsible party for carrying out many of these activities ranges from individuals and their families, local communities, emergency management, first responders, public health, and social service agencies. Many of the activities you see on this slide are especially challenging for people with dementia and their caregivers. They are also challenging to carry out for those agencies to tailor for dementia communities. Next slide, please. The role of public health departments in disaster preparedness are extensive and varied. Some of their activities are listed on the slide, including facilitating access to information for all populations, but also tailoring approaches to outreach for at-risk and vulnerable populations, coordinating with existing emergency response organizations and structures, and also developing basic surveillance systems to track morbidity and mortality, and maintaining registries for affected populations. In carrying out these activities and more, public health departments and their partners sometimes face resource, personnel, and infrastructure challenges to tailoring these approaches for dementia caregivers. Next slide, please. Therefore, our key question for today's roundtable discussion is, what is the role of public health agencies in disaster preparedness for people with dementia and their family caregivers? Our goal today is to stimulate discussion on real-world challenges and successes with disaster preparedness to optimize outcomes for people with dementia and their family caregivers. Our key audiences are departments of health and their partner organizations who support people with dementia and their family caregivers. And since we only have an hour and a half today, I wanted to provide some scoping boundaries. We're going to focus today's discussion on natural disasters. Man-made disasters like bioterrorism, chemical emergencies, active shooter or bombing situations are all important, but they present a unique set of challenges that we won't cover today. We are also going to focus on community dwelling people living with dementia, rather than those living in institutional settings. Even though we know more than half of nursing home residents have dementia, this is because entities such as CMS, the Center for Medicaid and Medicare and Medicaid Services, have emergency preparedness requirements for facilities to have plans for subsistence needs, evacuation, and resident transfers. And lastly, we'll focus on family caregivers and less on formal or paid caregivers, because that is the scope of the Center for Public Health Excellence on Dementia Caregiving. However, we do acknowledge and are happy to discuss the extent to which formal caregivers in the long-term care system play a key role in disaster preparedness, because they interact with and often provide bidirectional supports with family caregivers while delivering dementia care. Before I introduce our panelists, I'd like to share a list of resources that will just flash through very quickly. These are resources that we've compiled related to disaster preparedness for disaster communities. We'll be sharing this list of resources in a downloadable format on the center webpage. And with that, I'd like to ask our panelists to turn on their cameras, please. And I'll start with Nancy Burns. Nancy Burns is the coordinator of the Upper Merrimack Valley Medical Reserve Corps unit based in Westford, Massachusetts. She's been in that role since 2004, supporting vulnerable populations, including those with dementia and their caregivers. Nancy earned her national EMT certification that she's maintained for over 40 years. Nancy's passion for dementia advocacy began with her first summer job as a nurse aide in the rest home where many of the patients had cognitive issues. Years later, her newly widowed mother was diagnosed with Alzheimer's disease, from which she passed away in September of 2019. Nancy oversaw her mother's dementia care, and her experiences have shaped her views on Alzheimer's patients, caregivers, and family members. Next, we have Paul Dunaway. Paul is the Division Director of the Adult and Aging Division at Sonoma County Human Services in California. He oversees the Sonoma County Area Agency on Aging, or AAA. Through his division, Paul is committed to delivering programs and services that promote the safety, independence, and well-being of older adults, persons with disabilities, military veterans, and their families. Paul has been with the department since 1999 and is a licensed marriage and family therapist with a master's in counseling. Next, we have Jennifer Harris. Jennifer is the Director of Communications and Public Information with the Florida Department of Health in St. Lucie County, where she acts as the spokesperson for the department. She coordinates social media, special events, and marketing initiatives to promote the work of the Public Health Department. Jennifer has a public health background spanning 23 years, including overseeing community health improvement plans and community health assessments to advance age-friendly public health work in St. Lucie County. Jennifer was also a caregiver for her mother, Randy, who had dementia. So Jennifer has experienced firsthand the challenges in navigating services, managing her mother's periodic bouts of hallucinations and paranoia, and as Jennifer states in her own words, experienced the physical and emotional toll on caregivers who often forget or neglect their own health to meet the needs of their loved ones. Next, we have William Kennedy. William is the State Social Work Director for the Alabama Department of Public Health, which he's been with since 2010. William is responsible for developing and implementing training and programs for public health social workers. In addition, he develops training in the Center for Emergency Preparedness and Community First Responders. He has additional training himself, including transportation disaster response, city readiness initiatives, and Ebola training, as well as other emergency preparedness trainings. And lastly, we have Nancy Powerstone. Nancy is the director of the Redwood Caregiver Resource Center. This center is part of the California Caregiver Resource Center system, which is funded by the California Department of Aging. Nancy has worked in acute hospital, acute rehab, and community-based settings. Nancy has been working in the field of dementia care and family caregiving since 1983. She has many years of hands-on experience working with people with dementia, with traumatic brain injury, and their family caregivers. I'd like to welcome all 5 of our esteemed panelists. Thank you so much for joining us today. Okay, I think we can go ahead and take the slide down and show our panelists. Thank you, everyone. We're going to start with a couple of questions, and then after our prepared questions, we will have Robin moderate the questions from our audience. So thank you, audience members, for starting to put questions into the Q&A field. I'm going to start with Jennifer at the St. Lucie, Florida Department of Public Health. Jennifer, can you please help us understand the emergency preparedness ecosystem in St. Lucie County? What's your public health department's role? And how does the department coordinate with local AAAs and emergency management to assist people with dementia and their family caregivers?
Awesome. So glad to be here today. Thank you so much for inviting me. Our St. Lucie County Division of Emergency Management has the ultimate responsibility for planning, training, exercising all government and non-government agencies involved in coordinating a response for all of the disasters we would have in our community. So we partner with the Division of Emergency Management and several other partners to operate a special needs shelter for individuals who seek shelter from a disaster and have health conditions that require electricity for medical equipment, daily assistance with medical care like frequent dressing changes, or need cognitive care for dementia. Our role as the health department is to provide medical care and support staff for shelter operations, but we work with so many other partners in support of this effort, such as the school district who provides meals. We work with the St. Lucie County Sheriff's Office. They provide security for our shelter. We have EMS on site to manage any medical emergencies during sheltering. And then we also have respiratory therapists from local hospitals and many more partners that make our special needs shelter really operate well. In terms of collaboration, we participate in special needs shelter meetings, and those occur about 10 out of 12 months each year. We work with the Alzheimer's Community Care Group here. They're out of West Palm Beach and service our county. They attend these meetings regularly and provide input for shelter operations. And then our county also manages an online registry where residents that need transportation to the shelter can pre-register. And we partner with the county throughout the year to review that list. It helps us plan our shelter operations based on acuity and specifically for memory care needs as well.
Thank you so much, Jennifer. I'll turn next to our other public health department representative, Bill Kennedy. Bill, please help us understand the emergency preparedness ecosystem in your state, Alabama, and how you partner with your local AAA partners and emergency management partners.
Certainly. Thank you for the opportunity to speak today. And, the first thing I want to mention is that every disaster response starts at the local level and ends at the local level. And as the State Department of Public Health, we're here to support the local county and districts as needed, as the disasters management grows and it outgrows whatever is needed at the local level. That's where public health comes into play. Public health falls under the Health and Human Services ESF 8, the Emergency Support Function 8. And this consists of everything, including assessment of public health, patient evacuation, patient care, surveillance, public health and medical information, all the way up to mass fatality management. Here in Alabama, we have a lot of disasters, a lot of natural disasters, everything from flooding, tornadoes, hurricanes. And so being able to manage hospitalizations, hospital beds, working with our local agencies, our local AAAs, all of this falls under that ESF 8 part of the Health and Human Services. And so we work with our state EMA and our local, our federal partners at the federal level as well.
Thank you so much, Bill. I'll turn next to Paul. Paul, please help us understand how your AAA coordinates with local departments of health, emergency management, and other partners to assist people with dementia and their caregivers during emergencies.
Indeed. I actually want to first thank the audience for coming today and hope that we can provide a tidbit of information that you can bring back to your communities to help vulnerable populations and learn from the unfortunate lessons learned in our examples. So locally, I can talk about 3 different responses that we've had. The first is within California, we have an executive order that Human Services departments stand up emergency shelters. So that's our first and primary responsibility. during disasters, if people need to be evacuated, we have to attend to anybody who needs to be evacuated from any areas. Second, in something that I do just within my division, because we have programs that meet the needs of vulnerable populations, we have adult protective services, in-home support services, as mentioned in my introduction. Take that very seriously whenever we onboard any individuals to access our services, talk about their emergency preparedness plans first. Then if we have any forecasting about any disasters that are coming, some people think of fires as slow moving. That's not always been our experience, but sometimes they are, and we can contact individuals in the impacted areas to make sure that they have adequate plans to deal with whatever type of disaster that they're facing. During a disaster, we'll also do some reaching out to make sure that their plan was effective and to see if they have any needs. For example, during a very long power shutoff that our local electricity company did is brought water and food to some individuals who needed things. And then after disasters, we do some outreach to make sure that their needs are met and they can return to their communities. The third thing that I would want to mention is after our perhaps most devastating disaster in 2017, when we had a large scale fire that burned over 5,000 homes just in Sonoma County, and 22 people lost their lives. And really appreciate the slide that indicated 75% of those people in Katrina were over the age of 60. 20 of the 22 people who died were over the age of 60, and one had a disability who was under the age of 60. We learned as government organizations, we need to bring people together to talk about what needs to happen on all scales. Each of us have different forms of expertise, and many groups have expertise in what they know about their populations and how to respond to disasters. So essentially, we've become a community of first responders in trying to meet the needs of vulnerable populations.
Thank you so much, Paul. That's a very comprehensive answer. We appreciate that. I'll next turn to Nancy Burns. So Nancy, in Massachusetts, help us understand your role as a medical reserve coordinator and what your organization does in collaboration with departments of health and AAAs to assist people with dementia and their family caregivers.
Thanks very much for asking. One of the things that I've discovered over the years, as most of us have, is that the Medical Reserve Corps system tends to be one of the nation's best kept secrets. Briefly, the organization started because of September 11, when well-meaning people went to the disaster site saying, I want to help, but they weren't trained, they didn't know the lingo, they didn't understand protocols or incident command, and in a lot of cases got in the way or had to be managed, got themselves hurt. They'd say they were doctors, but they didn't have any proof. They might just want to do walletectomies. So someone had the great idea, why don't we actually harness the goodwill of people who really do want to help, make sure they're recruited, trained, credentialed, organized, and given some protocols and done drills with the other agencies so they would understand the system and where they fit in. Medical Reserve Corps people, including our own unit in Massachusetts, we never run the show. We are intended to be support systems. So if there's a disaster, and we've had several since I started in 2004, we've had emergency shelters because of storms. We've had people have to go to warming centers because it's cold, or cooling centers because the temperature be like triple digits and very high humidity. So that's where the MRC fits in. We cover 7 communities. Now in Massachusetts, when you're asking about how we operate, I can pretty much tie in with the previous speakers. Jennifer did a great job of talking about her elements and interagency collaborations. Bill in particular, local, yes. Massachusetts is hyper-local. 351 individual public health departments and 35 individual Medical Reserve Corps units. But what we have in common is, for example, the Department of Public Health has a liaison to the health departments and to the Medical Reserve Corps systems. So that's how we cooperate with each other. And as Paul said, with emergency planning before, during, and after, we try very hard to make sure that individuals have a plan. We do a lot of preparedness work, public outreach, for example, 72-hour kits, and making sure that we've spoken with some of these people, the caregivers, Here are some things you might want to know. If the person gets really upset without certain comfort items, make sure you have them. There might be places where you can't evacuate to a community shelter. I remember one time being the shelter manager when we had a big snowstorm and someone had cognitive issues and no caregiver and older. I mean, she was at least 60. And this woman wouldn't sleep, wouldn't sit still, was a wanderer. And I spent all of my time for the next 8 overnight hours keeping an eye on her, trying to not offend her, but she'd get up and, for example, there would be a container of snacks that people could have in the middle of the night if they got hungry, like cups of Jell-O. She'd be opening the dispenser and licking all the Jell-O and putting it back in. She'd be wandering around kicking people's cots and otherwise causing problems and wanting attention. So there are some people with dementia that wouldn't be able to go into a community shelter. We do have usually a small area off to the side. Maybe the cafeteria would be for families and the quiet area would be the gymnasium, quieter lights, less sound. If you have a person that gets startled by sound and isn't disruptive, they could go into that part of the shelter and do just fine. But it helps to plan ahead of time. The person, as they say, when you've met a person with Alzheimer's, what you've met is one person with Alzheimer's. So that's a general approach that we have. Make sure you plan ahead with 72-hour kits, contact information. If for some reason you're unable to help, can someone else help? And we also know that the caregivers need care. I'll end with one anecdote from a warming center that we had a couple of years ago. Husband and wife came in. The wife was a caregiver. The husband was very mellow and calm and kind with dementia, probably Alzheimer's, kept repeating himself, very friendly. So she sat him at a table and a lot of us had a great time talking with him. We didn't care if he kept asking the same question 100 times. He was a sweet guy. Meanwhile, she could go off into a private room and just vent because, as you know, if you've been around someone with Alzheimer's round the clock, sometimes they push that last nerve of yours. And if they're stomping on your one raw nerve, you need to get out to take care of yourself and have more to bring back to the person with dementia. So I hope that answered your question, but I'd be glad to answer any aspects of it you wish.
Thank you, Nancy. I love all the great takeaways as well. Such important work that all of you do. I'm going to next turn to Nancy Powers Stone. Nancy, your role in the Redwood Caregiver Resource Center covers a lot of family caregivers in Sonoma, Napa, Solano, Mendocino, Lake, Humboldt, and Del Norte counties in California. I was wondering if you could just give us an example of one of those areas that experienced a recent natural disaster. Talk about some of the challenges that you encountered related to persons with dementia. Are there any unique needs related to preparedness for dementia caregivers?
There are, thank you. So I'm wearing about 3 different hats today as the director of a caregiver resource center that serves 7 counties, some rural, 1 frontier. And we've had fires in 3 or 4 of those counties since 2015. So I also am one of the 5,000 plus people in Sonoma County that lost my home during the devastating Tubbs fire in 2017. Running for my life like a lot of other folks because there was no adequate warning. Also being a caregiver for my in-laws at the time. So I can move in and out of my perception of my experience in those different roles. So I did want to say a lot of the things I'm going to say is input from the family caregivers that we have talked to during that time, feeling unprepared. Again, talking about the Tubbs fire in 2017, that Paul Dunaway was alluding to, there was no adequate warning. And we know people that are caregiving for someone with dementia need a lot of warning to be able to move people out if they need to in a way that isn't frantic, anxiety producing, and really stressful. The entire community of caregivers was caught off guard. Everybody was caught off guard. There were no special needs evacuation sites at the time. And we know that people with dementia are not going to do well. We just heard from from Nancy Burns, how inadequate community, just overall community evacuation centers can be confusing for people with cognitive impairments. And so, you know, really what folks need are low stimulation evacuation centers. One of the things that we do with all of our family caregivers now is a emergency assessment, a disaster preparedness assessment. And we look at some of the really basic things. Do you have, you know, medication? Do you need durable medical equipment? Is your person ambulatory? Do you have, will you have access to, incontinence supplies, durable medical equipment, all of those kind of things. The other things we've added in is, what if your person with dementia is in a daycare setting at the time? We had that issue happen in, the fire was in the middle of the night, but we did have the issue of people separated from their loved ones with dementia. So part of that preparedness is having a photograph of the person that you're taking care of with dementia, so that can go out in the event that you are separated from them. We also talk really early on with people about the value of a safe return bracelet. And that, you know, is a national registry. So really can be very, very helpful in the event that you become separated from your loved one, even in an evacuation center. And so that's part of that preparedness that we do with folks, also.
Thank you so much, Nancy. I'll turn back to Paul for a second, since you're also in California. Can you also talk about a recent disaster in your local area? And what did you do differently with people with dementia and their family caregivers, in how you addressed those needs versus other populations?
Yeah, so I think our first lesson learned, and I'm not thinking of the most recent, I'm thinking of the culmination of them, is that it's enormous how much really needs to happen, and how various efforts need to be instituted depending on whatever the vulnerability of any sort of population is. I think that there are government responsibilities, and then but what I was going to focus on in this is just about the boots on the ground types of efforts, and more of the AAA response that we did in our area agency on aging. We did a lot of outreach to communities that needed very specialized care, that I think it's harder for some government agencies to penetrate some of those communities, like inviting providers like Nancy Powerstone in Sonoma County to do more of that very targeted outreach. Another organization is like Latino Service Providers, where you have monolingual groups of people who are less likely to connect to government agencies, using those individual service providers to do that targeted outreach. We also organized, and I really recommend, a lot of neighborhood type of campaigns, get to know your neighbor, neighborhood watch campaigns. A lot of places already have these structures in place, but taking advantage of them to be able to really know what the needs of your neighbors are is one of the things that has helped, I think, in our community, but was so devastating in our Tubbs fire, because people didn't know each other quite as well. The other component is inviting people into the conversation as much as possible, certainly from the provider lens, but also from some of the organizations that house like assisted living types of organizations, making sure that they are prepared, and oversight agencies, so that they are all coordinated, know their evacuation plans, and can practice them in the event of a disaster.
Thank you so much, Paul. And your point about building community resilience with social connections is well taken. Let me turn to Jennifer then. Jennifer, in relation to disaster preparedness, what, if anything, does the Public Health Department in St. Lucie County do differently with people with dementia and their caregivers, and how you address other populations?
So obviously we work, like I mentioned earlier, we work with our agencies ahead of time. There are expos all over the county, some held by the cities, to really remind people to be prepared. In terms of our shelter operation, you know, we have our general medical floor, which the majority of our clients would fall into that category. And we, you know, kind of assign them based on their medical needs and acuity, and then nursing and support staff are grouped in teams around those specific rows on needs and acuity. So we shelter our clients with dementia with caregivers in a separate room, one that's enclosed, and we provide a higher staff to client ratio and provide 24-hour surveillance in that room as well. And to reduce wandering and potential clients to slip out, we do provide meals to clients in that room, whereas clients in our general medical floor, we want them to stay you know, active if they can in their ambulatory, and really encourage them to get up, walk around, pick up their meals, things like that. Also different from our general medical floor, we really try to maintain, like Nancy mentioned earlier, a very calm environment. And then we also work to keep clients engaged. To that end, we show old movies in there, we build puzzles with clients, and conduct arts and crafts activities. We're not able to really do that on the general floor with the number of clients sometimes that we have. And, you know, we really work hard to make sure that we select staff, you know, that we can pick them for some of their skills and be able to manage different personalities. Because as I think Nancy Burns mentioned earlier, one dementia client is not the same as another dementia client. So we want staff that can kind of roll with that. So we pick that, and then we have new staff. Sometimes we have turnover or somebody's out on FLMA. So if they miss training, we make sure that we do a just-in-time training with those staff on how to manage dementia clients.
Thank you so much, Jennifer. I'll turn next to Bill. So Bill, could you please talk about where you get your info as a public health department representative regarding people with dementia and their caregivers, for example, through registries or other data sources? And how do you use that information to prevent tragedy from happening during a disaster?
Yeah, certainly. Thank you. We actually have embedded in our department a lady from the CDC who has data that she's able to provide us, and it's down to the zip code of individuals that have registered and that we're aware of that have dementia. And so we know the areas where we may have individuals that may not evacuate because of different reasons. And so I know as a health department, we do set up medical need shelters. They're smaller than our mass care shelters, and we work closely with the different agencies, the Red Cross and the different agencies that provide those services. But oftentimes what we find are caregivers, family members who decide that they're just going to, you know, stick it out in their home. And so using that information to know where those individuals are and being able to communicate that information back to the local EMA representatives or EMS agencies. One thing we have here in Alabama that's unique and awesome is that we have a functional and access needs disaster task force. We meet quarterly. It's hosted by our state EMA. It's led by the Governor's Office on Disabilities, and it includes state agencies such as our Department of Rehab, our Department of Senior Services, Public Health, DHR, Department of Human Resources, and our Department of Mental Health. But it also includes representatives from the healthcare coalitions, the Red Cross, our Centers for Independent Living, and our Alabama Institute for Deaf and Blind, as well as other local agencies that participate on this task force. And so by having those connections, having those knowing those individuals and how to reach out to each other and communicate. Although we meet quarterly, we talk regularly, get emails back and forth, and pick up the phone with different representatives from those agencies. And so being able to communicate, knowing who to talk to and when to talk to them is a huge piece of gathering information on individuals that we'll need to provide support to.
Thank you so much, William. I'll turn to next Nancy Burns. Nancy, you had shared with a small group of us the Westford, Massachusetts Special Needs Emergency Registry. Could you tell us how Westford uses that registry with regard to people with cognitive impairments and dementia and their family caregivers, and how do you use that information to prevent tragedy from happening?
Thank you for asking. And what we do for Medical Special Needs Registry is something that anybody could do. Just look into it. We did provide a copy of ours. The town over also uses that. Rhode Island uses it. But the idea is people can voluntarily submit information about themselves or their households or the people they're caring for about the needs that they would have in a disaster. It doesn't guarantee that we're going to go first to one person's house versus another or evacuate them. What it does say is, what needs do you have if there is a disaster? What kind of support do you need? So we get the information, and let's say our town has 200 people in the registry. We might have some that are in the green category because there's 3 categories. Green means they may have some mobility limitations. They may have some mild issues that are managed properly. Maybe they have diabetes, but it's under control. So they might be in the green area. Further down is the yellow area. These people might have some comorbidities, some serious health issues. So they would need a higher level of care. The red area, those are the ones that you would probably want to go to first, or at least call first for the well check plan and say, how are you doing? They might be dependent on electronic devices. They might have like a serious form of heart disease or respiratory issues, that kind of thing. So if they have severe medical issues, cognitive issues, there are a lot of things that would put people in the red issue that, my gosh, if you don't get to them, there could be really tragic consequences. People sign up for this voluntarily. It goes to the health department, and the information is confidential. It is shared only with people who would be involved in the response at the time they need it. For example, the health department gets it, shares it with the police dispatcher. If we had a power outage and it's below 0 with high whipping winds, what calls and doorway visits do we have to make first? So the police would have it so they could do check-in. Fire department, if they have to go retrieve people or send the ambulance there if there's nobody answering the phone. We might also have the councils on aging, which have shared the information, for example, with our Medical Reserve Corps. So we would do well check calls. Wouldn't you know, we cover 7 communities. So we had maybe 10 individual members divvy up, okay, you make calls to these 20 people, you make calls to these 20 people. The senior center would call some that are especially confidential. They would say, we're going to handle these. Medical Reserve Corps, especially medical folks, please make these calls. It was a great opportunity. It worked very well in the past. There were some people that said, well, you know, I'm already getting the well check call. I'm fine, thank you. The senior center and my family are taking care of me. But you don't know. You don't know until you call. One gal in particular, she was very frightened because she was okay, but her person with dementia was really getting, I hate to say freaked out because of the storm, but with the whipping winds and the power outage and the wandering and what's not, my routine is messed up. What do I do? And especially maybe your medication schedule is off because you're having to go to a shelter or something. So these shelter medical special needs registries can be vitally important to say what individuals need care. If you look at the whole community, where might you go first? What calls do you need? It could be these people are under more serious medical threats, but they have power and they have extra people caring. So they aren't someone you'd need to go in and rescue. So that's been really helpful. And it's a great way for people like MRC responders to just make calls. And infrequently we've had them call and these people would just plain be lonely. So they'd spend 20 minutes on the phone with them because that's what they're doing. And the people would tell them all kinds of interesting things, like what it was like to grow up in the 1920s and such. So everybody wins with that sort of thing. So that's the Medical Special Needs Registry specifically. So thanks for asking.
Thank you, Nancy. I'm going to turn next to some lessons learned, and this is not at all a criticism for any one of the organizations that you all represent. Rather, this is more thinking forward about what kind of recommendations we can provide and offers of suggestions that we can provide to organizations like those represented in this call in today's webinar. So I'm going to start with Nancy Powerstone, and then I'll turn to Jennifer and Bill, since our main audience is public health departments. But Nancy, I was wondering if you could share with us some ideas of low-hanging fruit that public health departments can pursue based on some of the lessons you've learned from recent disaster preparedness work that you've done for people with dementia, what kinds of gaps can public health departments fill when it comes to disasters and dementia?
Yeah, I would love to. I think it comes down to early warning, early warning, early warning, right? Because we really want to avoid frantic escapes for people. And this is the input we're getting from our family caregivers. We had actually a client die and their person with dementia because of no warning and how agitated the care receiver was, and they expired between the house and the car. And so really just those earlier warnings have, a suggestion would be for people with functional disabilities and dementias to be warned at the very, very beginning. And our community did do in a fire a few years ago, they did a really, really good job of evacuating 190,000 people in a very systematic way, starting very, very early so that people could make those transitions for people with cognitive impairments much easier. Again, the need for very, very low stimulation evacuation sites, the need for, having available even, medication, an ability to get medication in evacuation sites, pharmacists there, personal care, all of those kind of things. We actually had a caregiver also slip and fall in an evacuation site, and they expired, leaving their care receiver unattended to because they had been taking some blood thinning medication. So we used a sort of a creative thing we used was we offered respite care. We used respite dollars, emergency respite dollars, to house people with dementia and their persons with dementia and their caregivers in hotel rooms if they needed to do that. And so we were able to keep their stimulation low and provide, that kind of alternative for them. So some of the things are really, really simple. And what we just hear is, first and foremost, just give us some time so we're not in that frantic rush. That's the low hanging fruit, right?
Thank you, Nancy, for sharing.
Yeah.
Yeah. Yes, because everybody is strapped for time and resources. And so I'll turn next to Jennifer. In your public health department in Florida, St. Lucie County, could you share some lessons learned that you'd like to share with other public health departments that are on today's webinar in the audience regarding what your Department of Health did regarding disaster preparedness for people with dementia?
Yeah, and I would say, most recently we had Hurricane Ian, and, we still feel so much for our counties on the West Coast, and we were so fortunate here on the East Coast with what we went through, and especially St. Lucie. We did open a shelter. We actually had 16 clients and 3 caregivers for that, but no memory care clients that came to shelter. And we did have a very short notice for opening up shelter. At first it was looking like it was going to hit Tampa, and then days before it kept shifting a little bit to the right. So out of an abundance of caution, they made a decision on a Tuesday night at 7 p.m. We're going to open a special needs shelter and 2 general population shelters. With our staff reporting the next morning by 8 and clients starting to come in at 10 o'clock. That's a very short turnaround for most of the things that we do. So probably a lesson learned is, when you've got to turn around that fast, with your communication enough in the beginning on how to get into the shelters, how do people get information? So we're looking at that right now on an after action report. But I think we could also improve on looking at beyond those monthly meetings that we have, having some more focused conversation with some of our service providers, providing different levels of care to dementia care organizations and to their families, looking at caregivers and what they need in our community. Are they looking for shelters? Are they looking for that respite care that Nancy mentioned earlier for a hotel? For less stimulation. I mean, we try to keep it down at shelter, but shelter is not easy, not even for the staff and everybody else, it's through different routines. So in contrast to Hurricane Irma that we had in 2017, we had a total of 265 clients and 18 caregivers. Still only 15 of those clients were memory care. So, you know, that looking at that now, even for this webinar, is why is that so low? And we do encourage people to stay where you feel most comfortable, where your loved ones most comfortable, because routine is really important. I know with my mom, the minute we went to a different location, we went into anywhere, she was paranoid about why she was there. It really threw her off guard why she was in a different place. Even if you told her we were going somewhere, then she would question why you were driving in the car. Well, why are we going there? What are we going to do there? I want to go back home. So, and then finally, I think just training. I think we've been very fortunate during Hurricane Irma. Dorian, we had a few memory care patients there, but that we haven't had a patient like my mom. And I think Nancy mentioned earlier, my mom had hallucinations, was paranoid. If she heard loud noises, she attributed that to people probably trying to come in with guns, really unusual things. We've been very fortunate that we did not have patients like that in the shelter so far, but I think you have to prepare for that. And then, you know, hope for the best, but we need to be prepared for those kind of situations as well.
Thank you, Jennifer. And since you've been talking about shelters, I'm going to grab a question really quick from the Q&A just for clarification purposes. Jennifer, you talked a lot about special needs shelters. Would you mind explaining to somebody who asked this question, what does a special needs shelter look like? What is different and how do people know this is available?
That's a really good question. So we promote the special needs shelters out through different government agencies. They use different social media platforms to remind people that there is a special needs shelter available. So we're looking to meet the needs of clients that have special medical issues, such as maybe they have ostomies, maybe they need medical equipment that has to have power, and they're going to be in a house that typically loses power during storms. And maybe they do have dementia, cognitive issues, and they need additional support during a storm. So when we look at setting up a special needs shelter for our medical floor, we're looking at beds and cots set up so it's not comfortable, it's a cot. Caregivers have to bring their own bedding and things like that. They have power by each cot to make sure people can have power for that. And then, as I mentioned earlier, we do have an additional room for memory care. But we also have a nursing team assigned to each row based on medical needs and acuity of the clients that are there. So we have trained nurses, RNs, and then we have support staff there to help as well throughout the whole storm.
Thank you, Jennifer, for answering that question on the fly. So, Bill, would love to hear your perspectives on lessons learned from your Department of Health and any advice you might give to other colleagues who are also from Departments of Health.
Yeah, thank you. Certainly. You know, here in Alabama, we don't say if there's a natural disaster, we say when we have the next natural disaster. And part of that thought process is, and I hear it often, is, you know, I've lived through a hurricane category 1. I didn't think it was going to be that bad. Or the flooding was just, you know, we've been through tornadoes. And so, you know, what's different? What has changed? And, you know, when you were, you know, 50 years old or 40 years old, it was a whole lot different than maybe when you were 70 years old. And now you've got medical conditions, you've got dementia, you've got other things that are going on in your life. And so, you know, planning and talking about that with people on a regular basis. And in addition, our Mobile, Baldwin County area down on the Gulf Coast, we had a huge growth in the last 10 to 20 years of individuals that are retired, that have moved south for a lot of different reasons. The weather's nice, the tax base here is lower, but they've never ever prepared for a storm like can come into the Gulf Coast. And so having those conversations, having those plans, using your toolkits and working with individuals that are in your agency that come into contact. The thing that we talk about at Public Health and through our Center for Emergency Preparedness if you don't talk to your clients, who is, about emergency preparedness? And so not just talking about it one time a year or one time, but throughout the year, because, we have the tornado season, then we have the hurricane season, then we have the tornado season again, and then we have, so it's always something going on that you can be preparing for and talking about and having an awareness of. And then the last thing I wanted to share, one of the things that has come out through studies here, people know the county they live in, and when the newscaster, the weathercaster has the little county, it's usually 4 or 5 counties that are at the bottom, and they'll have the warning there. What we learned is that a lot of people don't necessarily know their county when it's not on the whole state. And so they asked, why didn't you leave? And they said, well, we didn't think it was coming toward us. And so our weather forecasters here have done a really good job of saying, the tornado is in the Smut Eye area. It is headed through the all of these little small communities, and they name them. And that way people have a heads up of, do I need to react now? What do I need to do? Do I need to evacuate? Do I need to get in my safe space? Those kinds of things. And so just being prepared and knowing how to prepare for each of the different types of storms that we might encounter here in Alabama.
Thank you so much, William. And I've heard you say before, the situational awareness is so important. It needs to be much broader than just your local community. So thank you for sharing. I'm going to turn next to equity, and I'll pose these questions to Paul and Nancy Powers-Stone. So equity is obviously an important consideration for people with dementia and their caregivers. Those that are underserved include people who are minoritized racial and ethnic group identities, who have limited English proficiency, may be of lower socioeconomic status, live in rural areas, or have reduced access to resources like broadband internet access. Can you talk about what kind of equity considerations that departments of health and their partners should be considering for people with dementia during disasters? I'll start with Paul, if that's okay.
Oh yeah, I jumped in anyway. I really appreciate this question. I want to start with that. And I think that we always talk about people with vulnerabilities, and just want to really spread that is a large group of people. We think of people with vulnerabilities as people with a disability. It's also older adults, it's children who are dependent on parents. And especially it's minority groups. Many groups don't speak the common language that's in that community. And translation just has to be the foremost easiest thing to do whenever we're sending messages about disasters, of course. The thing I'd emphasize the most, though, is inclusion. Having any sort of disaster planner needs to be thinking about how to include minority groups or communities first in anything that they do related to preparedness. So being in that community, inviting voices, and making sure that the resources are there for people with less power and less resources is key, I think, in that. The other thing that I would mention is recovery, of course, looks different for all different communities, and anybody that comes from a community with less power and less resources needs more resources and unique resources, and the accessibility of those resources is going to be more challenging for certain communities. So being sure that you have local points of access within each one of those communities to be able to deliver services and resources in a timely manner is critical.
Thank you, Paul. Nancy Powers-Stone, would you like to jump in?
Yeah, I would. I just have a few things to add, and I'm going to talk from the sort of the frame of reference of looking at rural areas. In our rural counties that have been affected by, by natural disasters, a few things come up, and the biggest one is transportation, right? That huge question, where do I need to go and how am I going to get there? Some of the challenges of one road in, one road out, one way in, one way out, that happened in the fire a few years ago that destroyed the town of Paradise in California, even the interstate, one way in and out of the town. And so people had to wait and wait and wait and wait. So really look at alternatives to alternative evacuation routes is really, really important. We actually had a family caregiver and their person with dementia expire because at the bottom of their road was blocked by fire and they had to go back home and try to wait it out, and they weren't able to do so. They expired. And so really looking at that, a lot of rural folks have animals that they don't want to leave. That has been a really big issue. And so having plans for either livestock or other kinds of pets for some of our rural areas. The digital divide is a big deal in some of the rural counties in California. It is across the country. So sometimes the warning systems are not going to work. Cell phone towers were down, but also just people being able to get information in a timely fashion. And it's going to take people longer to evacuate, right? Because they just have longer, the geographic isolation of rural areas creates that issue as well. So I think.
Thank you, Nancy. Didn't mean to cut you off, sorry.
No, that's it, thanks.
Okay, great. So I have one more question, and then I'll turn it over to Robin Stone to moderate the discussion from the questions from our audience. My last question is about recovery and resilience. We've talked a lot about preparedness and response before and during natural disasters, but obviously there's a lot that can be done to help people with dementia and their family caregivers recover from disasters and be resilient to further disasters, future disasters, and their negative impacts. So things like coping with trauma, stress, anxiety, and grief, addressing the economic impacts of disasters, returning home and dealing with the changes of environments. I wonder if, Bill, you could talk first about what public health departments and their partners can do to foster recovery and resilience from disasters for people with dementia and their caregivers.
Yeah, thank you. As I think of disasters that we've had in the past, we put boots on the ground, set up tents in those areas where different resources are available, including partnering with, whether it's through our Department of Human Resources, our Department of Mental Health, our senior services, our AAAs, and having those right there available for those that are experiencing the after effects of a disaster. And again, those partnerships start well before the disaster, and then finding out what are the needs and putting them back in those communities. Oftentimes, you just need somebody to talk to and somebody to help you work through the process of applying for resources and services. If the disaster reaches a level, we're bringing in the National Guard, we're bringing in other resources to help meet those needs. In a tornado we had just a couple of years ago that hit a small rural community in Alabama, just south of the Auburn University. We had 23 individuals that died in that little small community. And so we partner with our Funeral Home Association, and they brought in our SMOR team, our state mortuary team, and they came in and provided services in helping to identify the individuals, and then also helping to the local funeral home, the local coroner's office with those resources. So it can be a lot of different things that go on, but all of those are helpful to the community and helpful to the families.
Thank you. I don't have that much more time, so I might just ask one other person to jump in, volunteers. We'd love any volunteer to just jump in and answer that last question again about recovery and resilience from disasters. I'll just take one last comment from anybody who wants to volunteer. Nancy Burns, thank you.
I'd be happy to jump in. The important thing is mitigation. If you've been through some of these as well, you know what made it hard the last time. So you try to learn from the previous disaster. As I think it was Bill mentioning from Alabama, that when are we going to have the next disaster? Not are we gonna? Our town manager is really particular about making sure all the trees are trimmed so that we don't lose power as often. And that seems to help a lot because the lack of power is big. Healthy communities is a big part of resilience. Are you doing the best you can to be strong before disaster happens? Do you have some of the supplies that would be helpful, like backup batteries and phone information so you could reach people out of state if local lines are down? Have you kept up with your health? I'm a huge believer in that. If you keep yourself strong, I happen to teach fitness classes, so why not get people to feel, are they applying measures like eating right, getting enough rest, getting exercise, staying socially connected, all those things that keep individuals strong, having a network of support, especially for people with Alzheimer's that are caring for family members. Jennifer and I both took care of moms for a long time that had Alzheimer's. The conditions were very different, but there's a lot of commonality to, we need to be careful. They're not thinking because they, as clearly as we might, because they have a cognitive organic condition, they can't stop certain behaviors. So we just have to try to calm them as best as we can and rein them in. But if we could, especially more important than anything, is educate, be ready ahead of time, have your 72-hour kits, do community outreach, make it available what the resources are. Are you well hooked up yet with your senior center? Can they refer you to other people? So all of these things you would do ahead of time to be ready is a really important thing.
Wonderful advice, Nancy. Thank you so much for sharing. I'm going to close our prepared questions, and thank you all for answering those. I'm going to hand it over to Robin Stone. And Robin, I would love for you to help lead us through the questions that we received through the Q&A in the Zoom chat box. Thank you so much.
Sure. Great to see every one of you. There are so many questions. I'm trying to organize them in my mind. And then every time I think I've got a question, you all have touched on it. So let me first, I want to open this up. I'm going to speak from the Q&A, but I have someone who's living with dementia who has a little bit of trouble writing the Q&A, and I would like to open this up for Michael Ellenbogen. Hopefully, Michael, I'm saying your name correctly, to just, give us your question online. So we're going to open the line up for you to talk.
Can you hear me?
Yes, we can hear you.
Thank you. My name is Michael Ellenbogen. I'm an international dementia advocate who is also living with dementia. I have high credentials working at the Red Cross. I actually used to do disaster relief, and I tried to start a program for dementia in Pennsylvania, which unfortunately was unsuccessful. I had to give up my Red Cross because of my dementia. My question to you, and you have touched on it a little bit, but I think what needs to happen at a national level is we need to put some kind of program in place that identifies people with dementia in their homes so they can register. And I think it would be great that if it be tied in with the 911 system, because there would be very benefits. And again, this should not be mandatory, but something that they are willing to volunteer to do, similar to where we have on the refrigerator that we put the prescription or the emergency thing for the fire department to come in and see, and have a tag similar to that. Because as a person who's living with this disease, I deal with many people who have dementia, and a lot of them, if they see a fire department, might even fear and run away. So it's important that these folks understand before they even come to the environment what they're up against and how to even deal with a person with dementia. If you are looking to do something like this, I just put my name and information in the chat. I would love to work with you. I have a lot of connections with people with dementia, but I think a national program, and I'd love to work with the Red Cross again, because I think you folks do fantastic work, and I'd love to create a program that works with people with dementia to expand on this.
Thank you, Michael, so much. And actually, this ties into a few other questions that we've had around registries. A number of you spoke about your registries, but one of the questions was, How do people even know that the registry exists? And what do you do about people who are reluctant to sign up for the registry? And the final question around the registry is, what do we do about registries in really large cities? Are there examples of registries? I just came back from a meeting in New York yesterday, and I was thinking about, geez, how do you get registries for these huge metropolitan areas? So I don't know if anybody can speak to this, but I think Michael raised the point. How do we get this to become more normative? Anybody have any ideas?
I know that in Westford, you can't force anybody to do that. Some people want to be private. Who would want the world to know this is a great house to break into because they're vulnerable? So people volunteer in our town, but how do we let them know? Michael, was that his name?
Mhm.
That we put it on the web, make it available. We have community events where we talk about it. We go to the senior center and talk about it. The staff knows about it. So informally and quietly, we do let as many people know as possible. There's also an organization called Dementia Friendly America. That would be a great place to do it. Individual communities like we have Dementia Friendly Westford. So in your community, you can figure out what resources you would need to get the message out.
Okay. Anybody else have any thoughts? One of the other questions related to registry was, how do you maintain these registry? Do you have a staff that are responsible for it? How do you make sure that the registries are up to date? Do you do any work around that? Any of you who already have a registry in your system?
For us, it's primarily the senior center because they know the people are vulnerable. And you do have to check it regularly because people are very sick and they pass on and new people get onto the list.
Okay, thanks for that. I have a couple of questions from Helen Metzger, who was, I think, a Fed. I think I know Helen. And so I wanted to ask a couple of questions that have to do with policy. The first is that there is, through the U.S. Department of Health and Human Services, a national plan to address Alzheimer's disease and related dementias under the NAPA Act to update and expand. And under that umbrella of long-term support services, what recommendations would you like to see put forth as part of the plan? So really from a federal level, what disaster preparedness themes should be incorporated in the plan? Anybody have any quick ideas to throw out? I also think this is something that the Bold Center could work on as well. But, you know, if you had to prioritize your key themes, what would they be? And this is open to everybody. Anyone? Particularly the public health department people? Jennifer, you look like you want to answer. Maybe this is something that we actually need to work through the Bold Center and get a group together to think about this. I think it's a very important piece that needs to be part of the plan. An additional question that Helen asked, and I think it is a good question about training, is that the state of West Virginia actually requires dementia awareness training for all first responders. Should all states require dementia awareness training for first responders? How do you all feel about that?
I was a benefit with my mom for having our first responders here in police and sheriff's office being trained well. They knew how to manage my mom when she took off in the car, and I had to kind of corner her into a gas station and wait for the officers to get there, and several calls to the house. So I think that's been a goal of our Alzheimer's Community Care Center, is getting first responders, sheriff's officers trained. And I think that's been a great success in our community. So
anybody else? Anybody have examples of training right now or things that you would like to see?
Hey, this is Bill Kennedy in Alabama. About 3 or 4 years ago, Alzheimer's was moved out from under mental health and over to the Department of Public Health. And so that's something we've taken on, and unfortunately with little to no funding. However, we do provide continuing education through our distance learning. We have a studio here in our building where we provide continuing ed, and that's available through our public health, our website. And so That's one of the things we bring in speakers to come in and talk, and have done that in the last couple of years to talk about dementia, not specific to natural disasters, but just in general.
That's great. Anybody else? Jennifer?
I was gonna say, Robin, there's another question by Haley on there about mental health supports.
Yeah,
for
yeah.
caregivers during disasters. I mean, we've got some things happening now in our state for after, because Hurricane Ian for the West Coast, there's been so much disaster there, and they really need that support. But we have had a family come in with a schizophrenic, very paranoid schizophrenic son with medications, and I think they were even running out of medication when they got to our shelter for Hurricane Irma. And we had to work with a local pharmacy to get medications in, but we had to make, some accommodations for them at the shelter. They could not be in the general population or medical room for that. They really needed to be isolated and quiet and calm as well. So I think we do have more work to do with what are those special need populations and how do we reach out to them and work in our mental health pieces with that too. And we did have 3/4 of our staff be EAP after that. That was a 6-night, 6-day sheltering duty after several days and no sleep. And I mean, the staff get a little weary. So
Yeah.
So it is a big need. So
Yeah, I think it's great. I think all the questions around the mental health supports, including those for family caregivers, as well as the staff who are working. I know Leading Age, actually, we have a set of providers across the full continuum who have met many disasters, and we actually have provided free massage therapists to go and work with the staff who actually were the emergency response providers. For many months, actually a couple of years, we sent massage therapists out to actually help with reducing the stress of the people who were actually responding. So it's really got to be part of the infrastructure. I guess there's a couple of other questions here that I wanted to throw out in the time that we have. One of them has to do with really connecting with community volunteers. And this ties in with the first question that we had around, why didn't you call me? I don't care if your phone lines are down. I don't care whether your emergency preparedness people are busy with other things. And in a lot of these situations, we don't have the technology to really get to folks. And Diane Cohn talks about a community volunteer program with family caregivers to provide weekly respite in Northern Colorado. And I was just wondering how many of you, we talked about neighbors checking on neighbors, but how many of you actually involve significant volunteering in your programming so that you can get to folks when they don't have the technology or other ways of reaching them? Anybody have any thoughts on that?
The Medical Reserve Program is all volunteers. So that's basically what we do. The
Okay.
misnomer is saying it's medical because about 1/3 of them are non-medical and we need all of them. So it's more a matter of, are we authorized to go to homes and look in them in person or find other ways to do it using cell phones, text? Setting up the networks ahead of time is even more important. So that's more helpful.
Okay.
Yeah, I'll jump into that too. And I just want to say that first question really stands out, and I appreciate it because it's the voice of many people out there. I think one of the first thing that comes to mind is public awareness. Many people think that cell phones will work no matter what. Even if the cell phone is still standing after a disaster, it has about 5 minutes on a battery life and everything's going to go down. So having multiple ways of reaching people is critical. All of our disaster planning efforts include the voluntary organizations that are active during disaster, also known as VOAD locally. They're at the table and they are pivotal in trying to help with these types of efforts.
That's great. Thank you very much, Paul. I wanted to just get to a question from, or actually a comment from Barbara, who says, I'm an ombudsman in Florida. Are all ALFs and nursing homes on a local registry? They should be on a local registry. And if they are, and many of our Leading Age providers are on a local registry, what if my neighbor in his own home with caregiver is able to register to know he has dementia? I actually think, even though we're not talking here about nursing homes and ALFs, because many of them are really required to have plans and register, we could actually think of them as the beginning or a foundation for a registry. that would add the neighborhood around these nursing homes and ALFs. So you actually had a community-wide registry that would include the institutions, the other residential care environments, as well as the home-based folks in one overall registry. So we knew where everybody was. You also could start to use some of these places as respite and even shelters as well. So I think it's a great idea from the ombudsman about including the nursing homes and assisted living facilities in these discussions. I don't know whether anybody uses them, anybody works with the nursing homes and the assisted living as well as the community when you're doing your emergency planning and as you're setting up your shelters and also in your recovery phase.
I could add that when we had an emergency shelter and we had one last client left who had some dementia, we did contact a senior center. Sorry, a nursing home. So they were willing to take him.
Okay, that's great. I have a question here about, I would be curious to hear how the panelists feel about the idea that there is no such thing as a natural disaster. They are disasters because they run into human populations and they become disasters. Are these underlying disparities something their public health departments are trying to address before disaster hits in order to alleviate the impact of the disaster? Things that are exacerbated, such as racism, classism, ableism, ageism, all of those things. So this is really the before disaster hits question. How much are you really thinking about this as a more fundamental problem in the community? And Bill, I saw you shaking your head. So do you have any thoughts on that?
Yeah, well, actually, one of the notes I'd written is, disasters are profoundly discriminatory. And, poverty here in Alabama is a huge issue. I think Mobile County, about 40% of the population is at the poverty level or below. And I've had individuals ask me, as I've been doing trainings and things, working with some of our groups in Mobile, I'm wheelchair bound, I live alone, I rely on public transportation. Who's going to come get me when you tell me to evacuate? How am I going to get out of here? And so, yeah, working on, as a social worker, working on health equity, health is a huge piece of what we do in public health on a daily basis. And, it's been an uphill climb the last couple of years with COVID. And certainly we've seen a huge decline in staff. A lot of folks decided it was time to go retire, or maybe they've moved on to other jobs. And so it's made the job even more difficult. But yeah, I would totally agree that the disasters, natural disasters are going to happen. Storms are going to come, and being prepared, and that individuals with functional access needs, with chronic health conditions, those that are directly affected by the disasters are going to see a huge adverse in their health outcomes after a disaster.
Yeah. We've got a comment about actually thinking about PCPs, primary care providers, and specialty providers as a way to reach out to people beforehand around things like getting signed up for registries. I wonder how many of you actually work with those types of providers in the community. I know working in aging for the past 45 years, whether you got a great PCP or a horrible PCP, most older adults really trust their PCP. And if their primary care physician is saying, you really should be signing up for this registry, they're probably going to take their advice. So I don't know whether any of you have any examples of how you work with primary care providers and other medical providers in the community. Any examples of that? I know we've talked about community-based organizations, but oftentimes it's that PCP that's the connector. And if not, do you think it's a good idea for us to be thinking about how we link with those types of providers and what kinds of information they need to actually know how to even help their patients to sign up for these kinds of things? Somebody was also asking about, is there an online kit? Does anybody have any examples of online kits that they could take a look at? And of course, these are things that we might want to think about in terms of putting together and the Bold Center might be able to put a template together around that. There was also a comment about we really probably need more than 3 days of medications for many of these folks who are taking multiple meds, and particularly for folks with dementia and other chronic conditions, not to mention their family caregivers who also might be taking multiple medications as well.
There are two resources people might want to know about, because there's no one right way to do a 72-hour kit or a preparedness kit or a jump kit or a go kit, however you call it. The American Red Cross has suggestions for what you put into a kit. Ready.gov has a lot of suggestions. The Medical Reserve Corps is really behind that, and we could submit pictures and tell us about the kits that we've had. We've also had kits that were specifically designed for the elderly. They might have more dental care, hearing care. They might encourage you to put in more batteries for hearing aids, a backup pair of like glasses, for example, comfort items, certainly like extra pairs of underwear and socks and medication. And you'd have to rotate your kit so that all that stuff stays fresh. But the bottom line is basic items so you could grab and go, because nobody wants to have to think in a disaster. You're so focused on get me out alive. You want to just have a kit that you can grab and run out the door with. And it's got all the basics that you would need anyway, even a set of car keys or a small amount of money to put into a vending machine. But there are a lot of resources like that. We could certainly provide that if you wish.
That's a great idea. And I think we could actually have this webinar all day. I keep getting more and more questions. I did want to let you know, because Lenny Levi Storms just put this in the Q&A. There is a new Frontiers in Public Health has a special issue on social determinants of health for the global aging population in pandemic and disaster environments. The abstract submission deadline is December 31st, 2022, and the manuscript submission deadline is March 20th, 2023. The link is social determinants of health for the global aging population in pandemic and disaster environments. We can put this up on the Global Center website as well, but I think it's a great idea for some of us to maybe think about how we might get a manuscript out around this, maybe even based on this webinar, because we've raised so many phenomenal issues as it relates to the people living with dementia and their family caregivers and care partners. So I think that would be fantastic. And Elma actually just put this in the chat. So at my discretion, I'm going to ask a question as well. And this has to do with the fact that I was years ago the Assistant Secretary for Aging in the Clinton administration. And I was there when Hugo hit North Carolina. And 2 years later, Hugo had still hit North Carolina. We had communities that we hadn't even gotten to in very rural communities of North Carolina. And I couldn't help but listen to the NPR piece on Puerto Rico yesterday, where 5 years later, power outages are still there, no medical care on Vieques. How is the money being used? All the money that was put into Puerto Rico, a lot of it is not being used. How do you all think about, we talk about recovery, but it seems to be somewhat short-term, and I wonder what kind of planning you all do for really long-term recovery, checking up on communities that are, one disaster after another, particularly where there's vulnerable populations like people living with dementia and their caregivers. Any thoughts on that? Any long-term planning that all of you do that you could share with us? Is this something that we could be working on in the future? This is the special issues call for papers in the social determinants of health for the global aging population in pandemic and disaster environments. For any of us who would like to address this, I think it would be great to try to pull a manuscript together. Let's see, running through the Q&A, we've got a few more minutes here. There's plenty of online training. Somebody, Tom Teasdale, says there's online training at the University of Arkansas Med System for first responders. So I think we probably have, and maybe we can pull together more resources for folks in terms of what kind of training there is for first responders. Let's see if there's anything else. Oops, we only have 1 more minute, so I'm going to turn this back over to Elma.
Hi, everybody. Thank you, Robin. Thank you, everybody, for being here today. There's a considerable number of you in the audience who are stuck here with us to the end. It's been a great panel and a great discussion. Just as Robin, I wish we could have this all day long. My name is Zelma. I'm the coordinator of the Public Health Center of Excellence on Dementia Caregiving. As we have seen from heard today from our wonderful panelists, really the ecosystem of emergency preparedness and response looks different in each state, but there's a lot we can learn from the experience and the work of our panelists and from each other. So we hope that you in the audience are leaving today's panel with ideas of activities and new partnerships you can build to prepare your communities to support people who live with dementia and their family caregivers. And just briefly before we adjourn, we wanted to share with you that we have 2 great upcoming webinars planned as well for November, which is the National Family Caregivers Month, by the way. Many of you know that. On November 15, we will be kicking off our virtual public health roundtable series, where we will be presenting the work of one state at a time that has taken an innovative statewide public health approach to address dementia with a special focus on activities to support dementia caregivers. This will be mainly for public health agencies, so a smaller audience. It will be broadly disseminated through national associations such as NACHO, ASTO, and the National Association of Chronic Disease Directors. If any of you in the audience are public health agencies, you want to attend and you haven't been able to register, please email us and we will get you registered as well. And the following day, on November 16th, we will be holding the second webinar, this time on the topic of stigma that exists around dementia. What are some cultural considerations in stigma and how it affects the lives of people living with dementia and their caregivers in diverse communities? So with that said, we're ready to adjourn. Thank you so much for being today. Maya, I don't know, maybe we can show the last slide with the contact information for our center. Please reach out to us with any question and any other resources you would like to add to today's list of resources related to natural disasters. Thank you, Dr. Shi, Dr. Stone, for facilitating today's panel.
Sure. Bye, everybody.